My name is Parminder Sachdev. I'm co-director of the Center for Healthy Brain Aging at UNSW Sydney. I would firstly like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples. Today, we are privileged to host Professor Rajesh Kalaria, leader of the Neurovascular Research Group in the Translational and Clinical Research Institute at the Newcastle University, United Kingdom. He is a professor of pathology in cerebrovascular diseases and also a neuroepidemiologist. Professor Kalaria's interests include the interface between Alzheimer's disease and vascular dementia, post-stroke dementia, and small vessel diseases of the brain. He is, in fact, the world's leading neuropathologist in cerebrovascular diseases. He's also contributed to the consensus criteria for vascular cognitive impairment and leads dementia research projects in indigenous populations of developing countries, particularly sub-Saharan Africa. Professor Kalaria is a member of the Africa Task Force of the European Academy of Neurology. He's currently the liaison officer for the IVRO-WFN and president of the International Society for Vascular, Behavioral, and Cognitive Disorders.
Okay, hopefully you can all see this first slide. And I'd like to say in the beginning that these slides can be available as a PDF, which I will send to Laurie. So you can then have a look at them later on at leisure if you wish. So this is where we are in Newcastle, up in the northeast of England, about 250 miles north of London. And Newcastle is has been an important center for dementia studies for the last 50 years or so. We are sort of on the River Tyne, as all big cities are, and that's what you see. On the one side is Newcastle and the other side is Gateshead, but we just refer it to as Newcastle. But in the first slide on the left in the bottom, you see where our campus is, Campus for Aging and Vitality, which is what's I mentioned on the slide. Also, my email address is on the first slide, so you can contact me if you have any questions to follow up. So nothing to disclose, and these are some of the questions that I want to answer today. I think a little bit of introduction, which might just help where we are. What types of dementia really develop after stroke? I think that is an important question, has been an important question for the last 20, 30 years. And then what is the neuropsychometry? And I know that Professor Sachdev and Shiba have done a lot of work on this, and the StrokeOg Consortium also has addressed many of these questions already. But I want to tell you from our perspective what we find. And then some risk factors, neuropathology of PSD, what is it? Because we don't know this really. There are no longitudinal studies that have been conducted. And we can sift through the data and troll through the data all over the world, but there's not a clear answer. So we've been privileged to explore that question in a prospective series. And then, of course, I want to say a bit about white matter disease in this context, and an animal model. I'd like to share the data from that too. Now, going back to, I think, the beginning, we could go as far, if you like, to the Egyptians, but I think we'll start with Willis. And so this pendulum seems to have sort of swung from all things vascular to the Alzheimer's syndrome. And then I think we're back to all things vascular, and particularly VCI. And really going even back to Binswang and Alzheimer, arteriosclerotic dementia was described, and then of course the hype of AD came. But as you look at the sort of historical landmarks in this particular slide, two things become obvious. There's been progress in terms of trying to better define the multiple lesions after stroke or as vascular disease, how they are associated with cognitive function or cognitive dysfunction, if you like. And even coming to modern or recent times, even Professor Sachdev has that term vascular cognitive disorder that was described in some of the publications in the part of a consortium, and that continues. And then there's the VCI and the VIX consortium as well, which I'll mention just briefly. But I want to mention why Newcastle has been important. And that is in the late 60s, early 70s, two seminal, I would say uncovering really, or rather than discovery, was apparent. And this was the work of Tomlinson, Blessed, and Roth. Tomlinson was a neuropathologist, Blessed, a neuropsychologist, and Roth, as you all know, was an old age psychiatrist. And they produced two seminal observations. One was that the burden of neuritic plaques at pathology was related to cognitive function before death. That was an important finding. And second, that the loss of tissue after a stroke, 50 to 100 mils, was also related to cognitive decline. Obviously, stroke at pathology, but cognitive function measured in life just before death. So these were important, two seminal, I think, points to make. And these were published in almost obscure journals, actually. Journal of Neurological Sciences now, we don't even, it doesn't even have a high impact now, but these were important. So thinking about that pendulum, what really is vascular dementia, just to define that, I think it is really, we really don't understand VAD as such. And it's only perhaps the tip of the iceberg as suggested in this slide. For example, the less degrees of cognitive impairment are much more common and can still be disabling. So there are certain cognitive domains, and how do they fit into this big picture? And then, of course, as it also says, up to 64% of strokes have some degree of cognitive impairment. And do we then call that vascular dementia or not, or frank dementia? And then all of this then has led to thinking and rethinking and this concept of vascular cognitive impairment. And so when we go back to that original definition, the conventional definition of VAD is deficient, really. Basically, that's the bottom line. A stroke may produce multiple changes. And it's not associated necessarily with memory impairment, like as in Alzheimer's disease, as we think. And so this concept of VCI was devised by Hachinsky et al. And John Bowler and teamwork in Unity, and then define as well all things vascular, cardiovascular, cerebrovascular as well, and then cognitive impairment, a whole spectrum of things. And so some years ago, and I know Professor Sachdev is also part of this consortium, VIX came along. And just to give you an idea, really, VCI becomes a very difficult, because it's a spectrum. And then how do you then see it in practical terms, clinically and even pathologically? So then mild and major forms were thought of, and major really where VAD belongs. And under VAD, then you have post-stroke dementia, you have subcortical ischemic vascular dementia, multi-infarct dementia, and mixed dementia. Mixed dementias with all sorts of variable neurodegenerative pathologies, as in Alzheimer's disease or dementia of Lewy bodies, and even FTD, frontotemporal dementia, or FTLD, to be precise, frontotemporal lobar degeneration. So that's where we are in terms of VCI. And what we think about where VAD belongs into that spectrum of VCI, mild and severe. And then thinking about strokes, we could take a lot of data today And I just want to sort of, as a background, just give you this taste of one of them. A large study with 3,300 scans or so. This was an MRI Genie study published about 18 months ago. And this is a northern hemisphere, largely the centers were in North America and Western Europe. And what they found in this study is really summarized in this slide. I'm sorry, it's a busy slide, but hypertension comes out as an important risk factor, and diabetes is second, as you can see there, and carotid artery disease and atrial fibrillation. And then it's really the bottom line of all of this was that the small lesions were important, subcortical lesions were important, and also multiple acute lesions were apparent on the scans, and cardioembolism or thromboembolism in microemboli probably are a substrate for further things down the road. And so I think that's the important point to make, because individuals with large lesions and large strokes will not survive very long, or will be disabled, and whether sometimes it's difficult to really follow their cognitive progress, if you like. But the individuals with small lesions are going to survive very long, and it's really that impact of that small lesion. What does it do to the brain down the road, and what can we do about it in terms of management and prevention? I think these are the important questions. So it's really that on the as you see this, the process on the from the left on the second, small vessel disease occlusion, and that is, I think, is really the important one to think about in this day and age. These are the individuals who are going to survive long. So I think then we could ask the question: can we control the risk factors? And then at the bottom, where they might have cognitive impairment, depression, depressive illness, and a host of other effects on in cognitive domains. And so given that background, we of course then can return to our original question. What do we know from the literature? What is post-stroke dementia? What is it? And what do we find? And when we think about that, originally it was said that from the references that I've put there at the bottom, including there was another study of Didier Lees and et al. in a review in the Lancet, I think Lancet Neurology, where they also said that about 50% of these cases might have VAD, and the other large proportion might have Alzheimer type of pathology and stroke, or that mixed scenario. So, but what did we find? Well, let's then look at that in our study. Now, as I think all of you know, that stroke is a risk factor for VCI dementia, and VCI dementia can be a risk factor for a stroke, or multiple strokes even. And you see all these kind of scenarios in the literature. So what we thought about was that we would find individuals, locate individuals to the stroke registers on 6 hospitals in the Northeast, where they had the first stroke established by CT, and then allow them 3 months, 90 days. This was determined by a study before in Finland and in Canada, that the noise, if you like, after the stroke settles down, and at baseline, hopefully all the delirium and some of the other features will settle down, and therefore we could then assess cognitive function from 90 days onwards. So really then asking the question, what does that stroke, it might be a small stroke, how does it have impact down the road? And that's really what we focused on. I would say. And I would like to mention the point is that when you have a small lesion, it's almost like, you know, having other lesions, for example, to the brain that's hit. Could be, say, a traumatic lesion, or it could be a viral infection, as in HIV. All of these things down the road will have some consequences, as we see in a large number of studies around the world. So having that design, this slide basically gives you the design. So we enrolled stroke survivors 70 years and older from 6 hospitals. 3 months was a baseline. We started screening them at that point, clinical exam, also a whole neuropsychometric workup, and then annually followed over time. And with the Newcastle idea that we've always done in longitudinal studies is that we seek consent to look at the brain at the end of the day, as it were, after the first year, the patients are or the subjects are enrolled in the study. So we go back to the families a year later and say, would you consent to an autopsy or postmortem, so we can look at the brain and really compare what's in the clinic and what's in the what's in life. So we also had control cohorts and AD defined AD cohorts as well, and those cohorts with vascular dementia mixed as well in parallel, and all these then were followed up to postmortem. A similar cohort, by the way, was also set up in Nigeria, which I'll refer to later on. So what did we find? Well, yeah, don't worry about the glass. I think it's probably you are ready for that, and I've got a day to go. But on the right is the good news. So the glass is half full, where these individuals who had a stroke, some of them did live a little longer. They even improved in their cognition as measured with CAMCOG. And then they had another approximately 50% chance of another 5 years. And then we also saw that better outcomes if their risk factors were controlled, either to developing dementia or to death. And more than 60% were free of depressive illness. But it was bad news if they had more than 2 or 3 vascular risk factors, including hypertension, diabetes, high lipids, and that sort of thing. So the glass was half empty in that sense for this other group. And I think the clinical message is very clear, isn't it? When you think about this, that really controlling those vascular risk factors is important, either time to death or to time to dementia. And since then, so that was sort of the 8-year data. Then since then, we have now got the 12-year data, and 2 things are happening. And in fact, we've got the 18-year data now as well. 2 things are happening, 2 phases of those who decline to dementia. First of all, they have a relatively stable cognitive function for years after stroke. And then it seems like 3 years before they die, they have a very steep decline, and they wind up with dementia, and mostly vascular dementia, as I'll explain in a moment. So implications again here, clinician for the clinician, the possibility of the impending vascular dementia, then really strict control of vascular risk factors. Not rocket science, but I think this needs to be known, and it's important. And so how many then can we say developed post-stroke dementia out of this cohort? About 25%, and now it's coming up to about 28% actually in the larger going longer into the study. Average follow-up 4 years or so. Neuropsychological features, executive dysfunction, even memory deficits. And it's very interesting that a large number of these had medial temporal lobe atrophy. So we were thinking here, are these individuals developing an Alzheimer type of syndrome? Well, that was a good question. And so we had to explore that. And then, of course, we had to also look at the postmortem. At postmortem, we found that a large number had not enough Alzheimer type of pathology to diagnose for Alzheimer's disease. And I'll come back to this point in a moment. But let's see what kind of lesions they had in the brain. Now, remember, these individuals, first stroke, they were enrolled from stroke registers in 6 hospitals. And these are individuals who would survive a long time, in fact, and small. So, and that's exactly what happened. When we looked at the autopsies of 100 brains now from this series, nearly 100 brains, you can see on the left, the size of the infarcts, majority of them are small. Individuals who didn't develop dementia, PSND, compared to individuals who developed dementia, PSD, post-stroke dementia. And then when you look at the location of these infarcts, well, there were a large number of the cortical, as you see, about nearly 50% of individuals had cortical infarcts, small infarcts, only sort of less than 5 millimeter in size. But white matter infarcts really separated, if you like, those who developed dementia and those who didn't. And that was a clear-cut result. And of course, in addition to white matter, they would have had these other lesions, some other lesions as well. So more than one lesion was also an important factor in this. So most infarcts, less than 5 millimeter, cortical infarcts and lacunes were really the substrates for developing dementia, and particularly in the white matter or subcortical structures. And when we look at all the pathologies, some years ago, we had put this classification out, Newcastle categorization of vascular cases. And really, most of the cases were in this in category 2. We see multiple small lesions, microvascular changes, small vessel disease type of thing, and focal and kind of an insidious progression of that. And very few others we found. Of course, very few individuals had even large infarcts as such, category 1. Hemorrhages, I think there were only 2 individuals who had hemorrhages. And of course, those were not apparent on CT, as I remember that time when we enrolled them. And a few had strategic lesions, and some had mixed pathologies. And what were the proportions of these? We'll tell you the answer in a moment. But given that, we also collected the carotid arteries and the whole cardiovascular system, actually, the heart and the coronary arteries as well. So in looking at the carotid arteries, here classified sort of in radiological terms, mild, moderate, severe. That's what the radiologists have done before. Then we can see that in the severe atherosclerosis in the carotid arteries, internal carotid arteries, is related to a greater handicap as per the Oxford scale. And that was clear cut. And so then relating the carotid artery disease in these stroke survivors to what we find in the brain was very, very interesting. And as you see here, those who had severe carotid artery disease had larger number of cortical infarcts and very, so severity of carotid artery disease associated with greater numbers of small cortical infarcts. And it didn't seem to make a difference in terms of the size necessarily. Location was important, but not necessarily the size, as you see here. And it's a wide distribution. So all this says is that when we think about small vessel disease, it's really a mixed picture. It's not everything intracranial, and small vessel disease is the picture is contributed by really what's going on in the cardiovascular system, obviously. Looking at the carotid arteries, same way we can classify them as mild, moderate, and severe. Coronary arteries, yeah. And coronary artery stenosis was also, of course, related to the cardiac pathology that we see here. As you see, coronary artery stenosis severity consistent with greater degree of cardiac pathology, and these can all be quantified, and that's what we've done as well. And then the question, of course, is how do we then see what happens in the heart, in the coronary arteries with vascular pathology in the brain? Well, there is some contribution, as this graph suggests. As a weak relationship, but I think the bottom line point to make is that not all small vessel disease pathology that we define, sort of try to define as a pure thing, is really of intracranial origin. So we feel that given all of the data we've looked at, both from the brain as well as in the arteries, the coronary arteries and the carotid arteries, then it's clear that possibly thrombi, microemboli are responsible for those lesions in the brain. What about the neuropsychology or neuropsychometry? Executive function, I think this is not rocket science necessarily, and information processing speed was apparent, as been described many times before, and of course apathy was an important feature in terms of the non-cognitive features. And I think we could just use Hugh Marcus's graph here to show that the cognitive profile was very similar to the lacunar strokes and leukoariosis that in the scan study that described in terms of executive function, processing speed, and working memory. So then remember, we had seen medial temporal lobe atrophy, and therefore the question then was, are they uncovering an Alzheimer's syndrome, these stroke survivors with small lesions? And so we did arterial spin labeling along with individuals who had Alzheimer's disease as well, who were diagnosed clinically on Alzheimer's disease. And what we saw, that blood flow, particularly in the lenticulostriate arteries and the posterior cerebral arteries, was as much affected as it was in the Alzheimer patients. So again, it just indicates perhaps or suggests that maybe these people are developing Alzheimer's disease or Alzheimer's syndrome at least. And maybe the medial temporal lobe atrophy explains it all. And we also then looked at survival curves with MTLA as a predictor of survival to dementia, and you can see that it separates the groups here. Individuals with lower CAMCO scores had more medial temporal lobe atrophy than others, and that was also on the progression to dementia. So as at the bottom says, in terms of, sorry, I'll just go back to that one. Yeah, at the bottom it says, well, is MTLA associated with Alzheimer's disease, or uncovering Alzheimer's disease, or unmasking Alzheimer's disease? Well, at this point we thought maybe that's what's happening in these post-stroke survivors. And so, of course, we had postmortem material, and therefore we started looking at the hippocampal formation and looking at atrophy very carefully, and counting cells, and in the CA1 region, CA2 region of the hippocampal formations that were collected from both the decliners, the non-individuals who didn't develop dementia, and those who did develop dementia. And basically what we found was that these individuals who developed dementia had smaller neurons, the key neurons in the hippocampal formation, CA1, with a reduced arborization, and also there was some neuronal loss compared to those who didn't develop dementia. So there was hippocampal atrophy. But then the question is this related to Alzheimer type of pathology or not? Well, no, it's not. It's not. And that's what's shown in this slide. So they, and I don't want to necessarily, I can, but not, we had all these different groups. So we had controls, we had non-demented post-stroke survivors, then we had demented, the PSD, and then we had AD, VAD, mixed, and DLB as well in this analysis. And it's a massive amount of work in looking at both numbers of neurons and volumes. And the bottom line really is that in all these diseases, there's atrophy or in the CA1 neurons as well as in CA2 neurons to a certain extent. And it didn't matter whether you had plaques and tangles in the tissue, the atrophy, the degree of atrophy was the same. And neuronal atrophy, of course, discriminated the PSD, those who developed dementia, those who didn't develop dementia. So what this showed us is, and this was done with 3D stereology. You know, this is the state of art kind of way you can look at neurons. It really didn't make a difference whether you had plaques and tangles. There was atrophy the same. So we feel that there is a different arm, there's a different pathway to atrophy that is probably driven by vascular changes. And this is also apparent in Alzheimer's disease. And so that's where we are. And all of those, as I said, cases fit in that category. And so one can also then look at this in a quantitative way. In a large number of cases, these are just to give you an example of the types of lesions that one can quantify from scale of 0 to 3, amyloid angiopathy, arteriolosclerosis, perivascular hemosiderin, basically microbleeds, and then perivascular dilatation and myelin loss. And if we took all the PSD cases, and they would really basically are fitting in the top category here of VAD, at least most of them, of staging 6, as we've showed in this particular study, which was a parallel study comparing both AD, VAD, PSD, and mixed, and DLB. So what can we say then? What is, at least in pathological terms, post-stroke dementia? Well, most of it is vascular dementia. There is not enough Alzheimer type of pathology in these cases to diagnose as Alzheimer's disease. That was clear cut. In the 8-year data, when there were 50 cases, we said 75%, and now there's even more. It's nearly 79%. Close to 80% of the cases can be diagnosed as VAD, according to the criteria we have at the moment. And the rest were mixed. And there was one turned out to be a frontotemporal dementia in this. And small lesions and microinfarction that you can only see under the microscope was an important factor in differentiating those who developed dementia, those didn't. And then our data are not very different, really, from individuals who in life had PIB or Pittsburgh B compound ligand imaging. And so Vincent Mock's study in Hong Kong also showed that only 20%, 19.4% retained enough PIB to be called or to be diagnosed as such for Alzheimer's disease. So most of post-stroke dementia is really vascular dementia, as far as we can tell from the data. And then what about Nigeria? I mentioned Nigeria before. We we went to Nigeria because and to Kenya now, but because they have a different lifestyle factors and so on, and as well different diets. So is it different there? And really the answer is no. They also showed medial temporal lobe atrophy, and again, high frequency of early VCI in these cases. And we think that this medial temporal lobe atrophy is there, and that atrophy is not necessarily associated with developing Alzheimer's syndrome, but it's part of PSD. So, and MTLA, then we can say, is not really a robust marker for Alzheimer's disease as was originally thought anyway. And so doing the analysis, both and multivariate analysis, became very interesting in that sense that three things stood out. One, of course, was age, years of education, important. And then what came out is really daily fish intake pre-stroke was protective. And you can see by a very high percent of protection, is near 60%. So pre-stroke, moderate to heavy physical activities also came in, which I didn't want to mention yet, but the daily fish intake was protective. And so there's an important message here. We're not advocating eating fish if you don't eat fish, but I think it's a good idea. And then, of course, some of the data from Nigeria and others with Jessica's study here with Parminder as well, were put all together. And in this ethno-regional groups, taking in the Nigerian data altogether, diabetes mellitus came out as an important risk factor, taking all these different groups, which I thought was very, very interesting. We all thought it was very, very interesting. And I was expecting hypertension, but diabetes came out. So again, controlling risk factors that we know about, we can do something about. We can't do anything about age or genes as yet, but we can modify every other risk factor as such. A little bit about white matter, and then just an animal model, and I'll finish there. So, so those are going back to, of course, you can have lacunar infarcts and diffuse white matter lesions, disruption of white matter pathways. And we really don't understand the process. We put these diagrams on a slide like this just to kind of show sort of the way, the path, but we don't understand the details of those pathways as such. And so in trying to do that, we have tried to look at the white matter more carefully. We also know that white matter hyperintensity is found on T2 imaging, FLAIR, and other modalities are associated with stroke, dementia, and early death as well. And this nice paper from Hugh Marcus and Stephanie Debet some years ago. And so focusing on the white matter, we had the postmortem material, and we also have imaging from life in many of these individuals. So that was the thing to do, is to look carefully at the gliovascular unit in the white matter and see the components of these cells, as well as the inflammatory component in this network, if you like. So, and I can only show you a couple of results from these studies, but you have the time, but I think you might find them interesting. So we started then teasing out the cellular components of this gliovascular unit in the damaged deep white matter and compared those with Alzheimer's disease. Now, what we had found in life when we had scanned these individuals, as I think I indicated before, besides the medial temporal lobe, we had also looked at the white matter carefully, and you can see from here that those individuals who didn't develop dementia stable, and there were those who declined as had higher white matter hyperintensity volumes. And so we followed these individuals to post-mortem, as it were, and frontal lobe white matter was particularly a predictor for survival to dementia, or to death, in fact, but to dementia for now. And so these images here just basically show you where the sections are taken, and then we look at myelin and use sections to assess blood-brain barrier breach and other markers. So here fibrinogen is being stained for in these sections, and fibrinogen is taken up by these very irregular looking astrocytes, and they become plasmatodendrocytes that basically retract the processes. So we started looking at astrocytes first in the white matter, and basically what we found, as you see in the comparing controls, the PSD, PSND, that there's a very high proportion of this plasmatodendrosis in individuals who had high volumes of white matter hyperintensities. A very clear result and very interesting. And here in pictorial form, you get the idea. These are the astrocytes in green, as you see in the bottom panel. They become hypertrophic, cell body swells, and then they retract the processes. So the process are, remember, processes are each all juxtaposed to the capillaries, the blood-brain barrier. And so if you remove the and they hold the water channel measured by aquaporin 4. So when you remove and you retract those processes, you are removing the water channel as well, and these then die basically through a process of autophagy, the astrocytes. So you are then damaging the water movement at the blood-brain barrier, the capillary wall, and that may be a consequence, many consequences down the road. So that's what's happening in the white matter. Something else that's happening in the white matter is to do with parasites in the capillaries. And this just diagram just gives you an idea what a parasite is, as you see in the green here. And one can then label with all sorts of markers, including collagen 4, PDGFR1 beta, and so on. And we can quantify basically what we find that white matter parasites were reduced by a remarkable 40% in the frontal lobe of these individuals who developed PSD. But very interesting, we also found individuals who had white matter lesions and were diagnosed with Alzheimer's disease or with vascular dementia or mixed. They all had basically a drop in these parasites or parasite densities along capillaries. So parasites control blood flow, local blood flow, as you know. So if you lose that, then of course that blood flow and perfusion are probably both affected. And that may explain the increase in the white. And over the years, we've looked at many markers. Some had really strong effects that separated the individuals who developed dementia and those who didn't, and others not so clear. But very clear was the the presence of demyelination, plasmatodendrosis, and loss of parasites were very clear cut. And there were higher also microinfarcts as I explained before, in the white matter than those. So one can then kind of put all this together and sort of at least try to build a picture of how really the white matter tract network disruption really mediates, I think, cognition in that sense. And this may not just be limited to PSD, but also VAD and to a certain extent VAD in AD. Then looking at comparing what we found in humans with what might be how we could simulate or modulate that in animal models was something that was of interest. So we used the BCAS model, which is bilateral carotid stenosis model. And so one puts these coils, which are really piano wires of a certain diameter to occlude the two carotid arteries on each side of the neck of a mouse. And one can then basically replicate some of the pathologies that I've described in man, including lowering blood flow to the brain, carotid artery stenosis, as you see here, and all the behavioral features can also be, of course, measured and followed. But what was most interesting is that in these experiments, series of experiments, what we did, we wanted to measure the effect of environmental enrichment, or really, you can't make the mice undergo physical exercise. So you just put them in environmental enriched cages, which means that they have tunnels and they have wheels, and then they spin around, and they have lots of toys in the cages. And so we put mice that were in standard cages, nothing interesting in those cages, just food and water. And then for 3 hours a day, they were put in cages with lots of toys. And then also some mice in cages full-time, just in the environmental enriched cages. And so we wanted to see the effect of this in terms of how could environmental enrichment or physical activity modulate stroke injury after BCAS. And what was remarkable is that when we put the mice 3 hours a day, they had reduced strokes, recurrent strokes, by 50%, a remarkable 50%. And the bottom, these pie charts at the bottom show you the distribution of those locations, just as we did in human, same way in fox, and volume as well as location that you see here. So that was an important result. So just limited exercise reduced a large number of strokes. And what was the reason? Well, I think before we go to that, just to show you that the behavioral data also all meshed very well. Mice with 3 hours of environment enrichment improved, even in working memory. That's what the results showing. But when we looked at the bloods and the brain proteins, it was very clear that really they are with the environmental enrichment, they are generating lots of growth factors and reducing the clotting factors as well when they are put in environmentally enriched cages. And that sort of all the data fit very well. So there was a protection both of the blood-brain barrier and other markers that we looked at as well. So moderate physical activity or environment enrichment is really important in regulating both coagulation and plasma proteins. And this is the summary of those results. Okay, so what can we conclude about PSD? I think just going back to the clinical message I mentioned before, really controlling vascular risk factors is important. And we've devised this sort of hypothesis, I think, about 20 years ago. But I think it's been changing a little bit over time, where these risk factors, it depends on the degree and perhaps the initial impact of how it changes the vessel wall. And that then leads to a kind of a chronic hypoperfusive state. If you think about arteriolosclerosis, for example, it leads to a hypoperfusive state, an oligemia, and then that may give way to microinfarcts or microlesions, small vessel or capillary, even capillary endothelium changes. And as I indicated in the white matter data, that may then produce the white matter changes that we see, or lesions that we see on MRI. And this may then drive, this might all be driven to, depending on the initial impact or the lesion, where it is, to these pathways. And these could all be modified by environmental, even air pollution, for example, and genes. And I just want to say that I think that there is a difference to me, at least, although we said all PSD is VAD, I think in PSD, we are seeing sort of the early stages of VAD. So I think in time, we will realize that really what we say VAD, when we see the patient with memory problems who comes in the clinic and doesn't have Alzheimer pathology and now, or Alzheimer kind of scenario, and is classified as VAD with appropriate imaging evidence, those individuals may have had long-standing vascular disease. And with PSD, remember, we enrolled them when they had the first stroke. So they are still developing, if you like, or progressing in that spectrum, even that small spectrum from PSD to VAD, but all of this is VAD. I think that's where it's suggesting. And one other way to think about all this is, of course, that the frontal lobe is very important in all of this, particularly all things vascular. And maybe in the mixed dementias, we see there's a contribution both from frontal lobe as well as the temporal lobe. As we summarize Masafumi Ihara and I in this little article, that we thought that these two pathologies converge, and that's what we see at the end of the day as a full spectrum of dementia. I didn't show you data from the frontal lobe, particularly neuronal data, but it's very, now we've done some transcriptometric, transcripto of individual neurons carved out from the frontal cortex, particularly dorsolateral prefrontal cortex, pyramidal cells, and looked at, and there's clearly a lot of metabolic signaling and cellular communication dysregulation in these neurons. And so there's a disconnection of the frontal network with subcortical structures, and I think we're getting to the answer of what precisely it is. And all of this is not bad in reducing the prevalence of dementia, I think, or rather incidence even, better to say that. And so in the CogFAST study, we didn't really follow the vascular factors as such, but really, I think reducing vascular and controlling vascular morbidity is important, reducing the whole burden of dementia, whether it's PSD, VAD, AD, etc. So that's the summary of my what I presented. I think most of PSD is VAD, microinfarction, important substrate, and atrophy, I think, is an important target in terms of that there's really no relationship, atrophy of neurons with the presence of Alzheimer's pathology in the tissue. And animal models really allow us to study vascular risk factors. Okay, that's the last, and I have the privilege to talk, and a lot of these people, colleagues, Louise Allen, who's our geriatrician, heading the CogFAST study, very valuable to the study. Now she's moved to Exeter with Clive Ballard, so we miss her. So thank you for your attention, and I'll stop share there. And as I said, these slides are available.
Thank you so much, Raj. It's, as someone has already said, it's been an inspiring talk, and there's a lot that I've learned on this talk, and a lot of questions that I have, and also some of the listeners, attendees here in this webinar. And I can probably, I'll refrain from asking my questions, but go to the questions that have been posed by some of the attendees. And it starts with Chris Chen from Singapore.
I must apologize that I've lost all track of time. I'm so sorry.
No problem. We'll go over. I think we'll take a few more minutes.
I'm so sorry. Yeah. I was looking for my watch and I said, "Where's my watch?" And I didn't wear it.
I think this is the most interesting part of the talk anyways, the Q&A, and people look forward to it. So we won't cut it short. We just have to run it over. And if people have to leave, I guess they have to leave. I can understand that. Basically, Chris started off by saying that, look, this finding of seeing very little Alzheimer pathology in post-stroke dementia, that seems to be consistent, of course, in this study from Hong Kong as well. And I know there was a study from California by Helena Chu many years ago, which also showed the same thing, medial temporal atrophy, but not much Alzheimer pathology. And she thought it was ischemia that was causing the atrophy rather than Alzheimer pathology. So do you think, but he says that otherwise you tend to see a lot of mixed pathology in, say, older brains, like if you saw from the Chicago studies, Rush studies, that there's a lot of mixed pathology. So is it because we are selecting a special group here of the post-stroke dementia?
Probably, I think so. And those in the Rush group, they're quite old in their community, and so they may have had, and you see most of them had mixed pictures. So, and I think it depends also on the, as I was trying to say, that maybe the initial lesion or initial infarct or the insult to the brain.
Yeah.
And so that's why I think we see a very variable picture, and because we are seeing at the end, and maybe, when you have a small lesion, say in the frontal lobe, then it may modulate other things, and because age is also part of it, and may increase the neurodegenerative type of pathology. But looking at, we would have been criticized if we didn't compare AD group and VAD group as diagnosed with present criteria or the mixed, obviously, but we don't see any kind of relationship with these.
No, I think that's very interesting.
Plaques and tangles, and I think there's a different pathway. Yeah,
different. And you think ischemia itself really could cause atrophy? Wouldn't you think?
Yes, yes, it does, and it can. I want to emphasize that, and maybe this didn't come across, and I'm sorry for that, is that all the tissues that we have looked at carefully were free of infarcts. So they were almost normal appearing tissues. In other words, the injury was remote. Remote to where we were sampling from.
Sure.
And that was an important thing to do, or important point to make. So maybe it's remote injury, and then there's a process that sort of affects the cellular makeup of the tissues.
Yeah, no, I think that's very interesting. Now, the other question that has come through is about myelin repair. So there's a recent report of deficient myelin repair in old mice that may be related to age-related deficits. So do you think myelin repair is affected as well in vascular dementia or post-stroke dementia?
Yes. I'm sure that people would start looking at myelin repair. They can't understand the white matter lesions, and they refuse to even touch it, because the sciatic nerve and the peripheral myelin is so easy to, the models are established for years and so on, but they can't understand the brain. So I think what's happening is that there's this chronic situation of a sort of, in the deep white matter, hypoxic environment, and that basically hampers the oligodendrocytes for remyelinating. And so obviously circulation related, but there's a chronic hypoxia that in the deep white matter, and that probably affects the oligodendrocytes for myelinating, promoting myelination, I mean.
Sure. Now, the other question, I guess, and that probably relates to your demonstration of, say, carotid pathology versus coronary pathology, and that really the two didn't correspond very much. No. So the question is, when you actually look at, say, a cardiovascular risk index, and use that for stroke. How valid is it? And how should you modify the stroke or vascular risk index for stroke and perhaps for dementia as well, vascular dementia as well?
I think it's very useful, and I think we should explore that in a larger cohort.
Yeah.
I think it's clear, because I mean, you will see that I didn't say it so blatantly, but I think small vessel disease is a hype.
Okay. Yeah.
I feel that, because I think, you know, SVD is fine, okay, but intracranial change in the vessels, yes, fine, but I think when we think about SVD, is not just necessarily intracranial or intracranial origin. I think
it's not in isolation. What you're saying is it's not in isolation.
That's right.
Yeah.
That's right.
Yeah.
I think there's a lot of contribution from the cardiovascular system. Yeah, and that's why I think we probably don't have enough cases to explain and make a good correlation between the coronary and the carotid arteries and what we see.
Yeah. But why do you think there is this discrepancy? Why does, I mean, in some cases the coronaries seem to be affected, whereas the carotids are quite good, and vice versa. Some people develop carotid pathology but not coronary pathology. Why this different?
Well, one could be genetic. That we haven't looked at. We have got the bloods and all sorts of, you know, fluids from these individuals. Could be genetics, but I think also there's so much variability in even cardiac disease in individuals, of all, especially aging people.
Yeah.
That may, and so it might require a larger cohort really to sort that question out.
Yeah, it's
carefully.
interesting question to follow. I think to follow up.
And you know, and may relate to lifestyle factors, diet.
Yeah, sure. I mean, genetics, I think maybe there is a study there really that one needs to do. Now, I mean, one question that's come through is what do you think is the earliest detectable form of white matter lesions in the human brain? I mean, I'm not sure when you say detectable, the questioner is Sean Kong, where we're talking about MRI or pathology or neuropathology in the brain. What do you think is the earliest as a neuropathologist?
Oh yeah, as an early, I think white matter change is the earliest. Yeah. And
what do you see as the earliest change in
I think demyelination.
You see demyelination, as quite early.
It probably could be quite focal. Yeah. And I think this is what we explained before, is probably because you have the perforating arteries suffering the end arteries. The arteries are getting older, or at least, you know, more stiffer, and so not perfusing right in the deeper parts, and that hypoxia probably then relates to what we said before about oligodendrocytes and white matter changes coming. Yeah, I think it seems to me that looking at all these brains over a large series, including individuals from 50 onwards, you start seeing the arteriolosclerosis in the white matter more often than anywhere else.
Yeah. So Sean has actually followed up saying that he was talking about MRI. When MRI, what is the earliest change you think? You think DTI, when people talk about DTI, change in DTI, are they white matter abnormalities, you think?
Yeah. Probably with DTI is probably a better marker than, say,
flare.
Flare or MRT2, I think, in terms of seeing. So as soon as I think with DTI, the fluidity, that there's a change in the fluidity, another water movement, which might be, I think, a good marker to see early changes. Yeah.
And free water imaging.
Sorry.
Free water imaging, which is now becoming the rage.
Yes, exactly. Exactly. Okay. It's sort of that, if you like, how do you describe lose the loosening of that environment, or that milieu, the microenvironment.
Yeah.
Which obviously would not be apparent on MRI as such, unless you see those white blobs. But there are two things in the white blobs. I think we have to be careful. Is that, of course, now it's better with Joanna Wardlaw's and that consortium that decided that, okay, there could be perivascular spacing, but there could also, of course, there could be small infarcts too.
Yeah. So we are running out of time. So I'll just take this last question. See, in terms of recommendation, okay, control vascular risk factors, as you said, and you showed that the nice curves of increased risk factors and decline. Can we target other things? Of course, neuroinflammation is one obvious thing that people talk about, but don't know how to control it really. The other thing is ischemia. Can you actually target chronic ischemia? And in fact, related question is, does ischemia actually lead to regulation, homeostatic mechanisms in the brain that makes it protects it against future stroke or future ischemic attack? Maybe I've asked too many questions in this.
I think no, it's a good question. Absolutely good question. Yeah. Well, going back to any stroke, small stroke is a risk for more strokes. So I think at that point, strict control of all vascular, vascular risk factors that have become apparent is obviously top priority. And then if you want to differentiate ischemia versus oligemia, which is a very nice term. I really like that term because I think it exactly says what it is, where there's no damage to the tissue, but there's a sort of a hyperperfusion. And this, of course, this term has gone out of fashion. Being used. So I think maintaining, blood flow will drop in age with age. So I think just still trying to maintain that above the threshold would be the thing to do, really, in my view.
Okay. Well, thank you so much.
That should prevent ischemia down the road.
Yeah. Okay. Well, thank you so much. I think we could go on like this, but really we have to finish now. And thank you very much for generous time that you've given to this. And we certainly wish that you could be here, but certainly
it's been a privilege to be with you guys.